Prabhu? Okay.
Hello.
Prabhu, let me know when I have to start.
Okay, just say Roshan, sir.
Yeah. Roshan.
Just introduce, then we can start, Sajjan.
Roshan, no video.
Is Partha there?
Get audio, sir. We are not getting audio. Samir, sir. Samir, sir.
Samir, can you hear me?
Samir, sir, we are not getting your audio. Samir, sir.
Ajit, keep this.
Sir, our audio வரல Samir, sir. Try பண்ண போக மாட்டேங்குது. நீங்க பேசி introduce பண்ணிருங்க, sir. Sir.
Yeah.
Sir, நீங்க introduce பண்ணிருக்கீங்களா, sir? Samir, sir. Sir, okay. Okay. Okay, okay.
Yeah. Can you hear me now?
Yeah. I could always hear you, Samir. Can you hear me? Can you hear us?
Good afternoon, all. I welcome you for another session of Amasi Lens, where an eminent faculty, national and international, would present either a live surgery or a minimal edited video. This Thursday, we have an eminent faculty who is a director of GI and minimal access surgery from Glen Eagles Hospital, Mumbai, Dr. Prashant Rao. Active Amasi member and who headed a lot of positions at Amasi. He is going to show us tips and tricks of laparoscopic extended right hemicolectomy. To moderate the session, we have three eminent faculties: Dr. Tushar Mishra from AIMS Bhubaneswar, Dr. Kanagvel from Chennai, and Dr. Kunal Solanki from Ahmedabad. So I hand over the mic, the screen to Dr. Prashant Rao. Sir, over to you.
Thank you, Samir, for the kind introduction. And welcome to all of you, and welcome to the chairpersons, Dr. Kanagvel, Dr. Tushar, and Dr. Kunal. So I'll start right away. I've just interspersed a few slides just to make it more interesting and to give a background of a hemicolectomy. So basically, this is the history. We all know it. I'm not going to go into the details of that. We also are well versed with the advantages of laparoscopy, even for malignancy now. And contradictions are relatively obvious. T4 tumors are extremely large tumors, which can be difficult to manage laparoscopically. And certain, there are some complications which are dependent on your contraindications dependent on your expertise, where a less experienced fellow may not take up very large tumors. So one has to be mindful of this. And this is the vascular anatomy. There are certain critical points that one has to keep in mind. One is particularly Griffith's point at the left splenic flexure, and the other one on the right side. So this is the lymphatic drainage, which we are well versed with, and we need to take this into account when we are taking all the blood vessels. So the position for a right hemicolectomy is basically the patient is lying flat with his legs spread, and assistant in between the legs, a surgeon on the left side of the patient, and assistant next to the surgeon, and we have the monitor on the right side of the patient, similarly as we manage for an appendicectomy. We have an optic port which is usually in the umbilicus, and one port between the umbilicus and the xiphisternum can be slightly to the left of the patient for better mobilization of the ileocholic vessels and the central vasculature, and similarly a port between the symphysis pubis and the optic for dissection. And we have, if necessary, we can put in ports in the right iliac fossa and in the right hypochondrium for assistance if required. So usually we use the 30 degrees 10 mm optic at the umbilicus, and initially start off with 5 millimeter ports and then change to a 12 millimeter the uh, left hypochondriac port for stapling. And the specimen is either removed through the umbilicus or a phalanstele. The anastomosis can be intracorporeal or lap assisted through the umbilicus where we remove it. So there are two approaches, and usually we follow the medial to lateral approach, which was the classical Turnbull no-touch technique. Even though not proven in literature, that is what we all follow. And you can also do the lateral to medial. The disadvantage of the lateral to medial approach in laparoscopy at least is once you mobilize laterally, and if you are given a head low position and a right up position, the colon can flop down on the vasculature. So it's better to let the colon be attached to the lateral parietal wall before one mobilizes the vasculature. And what we also practice now is a CME with CVL, is a complete mesocolic excision similar to a TME for the rectum, in which sharp dissection of the vessel planes and entire en bloc removal of the mesocolon with the specimen with the lymph nodes, and a central vascular ligation. This is what we have always been following for this, and this is oncologically very sound. So coming to a right hemicolectomy, this was a patient with a growth at the hepatic flexure. This is a little extended because of the hepatic flexure lesion. We have taken the entire middle colic. Normally, otherwise, for a right colon, we would take either the right branch of the middle colic, or if the growth was confined to the cecum, you might leave the middle colic alone. This patient had some adhesions, as you can see, as we entered because of some past surgery, and these adhesions were taken down using an ultracision. We use an ultracision for all our dissection. It makes the dissection much neater. Even before the ultracision, we used to do these colectomies, but using a monopolar and a bipolar, extremely feasible. There is a excellent surgeon called Professor Brice Gaye in Paris who does all these colectomies using only a bipolar. And his take is that even a bipolar is good for all vessels, though it increases your intake of uh, instruments, ingress and outgress of instruments. You have to replace the bipolar with the scissors every time. And he has developed a forceps called the Brice Gaye forceps, which is a grasping bipolar. So all vessels can be taken with a bipolar, but especially in fatty people or when you have very fatty mesentery, the ultracision or the harmonic scalpel certainly makes dissection cleaner, faster, and much more appeasing to the naked eye is what I feel. It also helps you to find the planes. So initially when we go in with the optics at the umbilicus, we can see we have put in the lower port. The patient also has inguinal hernia, which we make note of, but don't do anything for that. And we also at this time see the liver to see whether there are any metastasis. Sometimes metastasis can be missed on PET scan or CT scans even, and are discovered at the time of laparoscopy. It does not necessarily preclude a resection, especially in colorectal malignancy, but one should be aware of it. We also make note if there is any peritoneal disease. Again, one can be aggressive in colorectal disease for resection, irrespective of metastasis, because survival has been seen even in the face of stage 4 disease. So this is the view that we get inside. The peritoneum looks relatively clean. The liver, which I have not shown here, but we have looked at, is clean. And you can see here, even in the pelvis we look, and there is no metastasis seen, there is no ascites. So the patient is actually a fit patient for a resection or a curative attempt for a radical hemicolectomy. So you can see that is the cecum and the ascending colon. It's relatively clean, and as we go higher up, we will see that the growth is closer to the hepatic flexure, and you can see we are seeing the IC junction. That is the IC junction, and that is the pericolic fat. We're looking for any metastasis. There is nothing to suggest anything that would preclude a resection. And you can see as we go higher up, you can see the growth which was at the hepatic flexure. Then we start mobilizing the colon. And here, when we mobilize the colon, initially it is important to lift the transverse colon, and we keep the patient in a steep head low and a right side up position so that the bowel moves away from the right and towards the left and to the lower part of the abdomen, the small bowel. the colon, because the head lobe naturally gravitates towards the head end of the patient, and we lift up the transverse colon to visualize the axis of the vessels. And the central vessels will be the that we are interested in will be the middle colic vessel and the ileocolic vessel, which are coming from the SMA-SMB axis. Now you can see here, this is where the growth is towards the hepatic flexure, and it seems to be a little adherent there near the gallbladder or the liver, which we'll have to separate, but may not necessarily be infiltration of the malignancy. It may be just physiological adhesions, or the patient might have had some attack of cholecystitis in the past. So that again does not preclude any kind of resection in such patients. So we proceed with putting of the ports, and we will proceed with the dissection. Yes,
Dr.
Samir?
Prashant,
Yes.
there are few people who will try and attempt these hemicolectomies in little right lateral, left lateral with some 30 or 45 degrees angle, so that they can the bowel falls down immediately. They stand on the left side. So
Left
would this,
lateral, or in the sense you mean right side up and
yeah,
left lateral position? Okay.
yeah.
So we keep the patient in a head low and right side up position, as I said. So it is essential so that the bowel goes away from the operative field and leaves the vessels exposed. So that is a classical position for a right hemicolectomy. Now we are trying to see the vessels.
Yeah. Any tips if the small bowel is distended because of some bowel preparation given one day prior?
So usually for right colon, I would not advocate bowel preparation. We only prepare the bowel for a left colon. Even that in literature is not proven. And especially if the patient is obstructed, it can be dangerous because it can also lead to perforation. So I would not routinely recommend preparation for a right colon, because
Okay.
you see one side of the anastomosis is small bowel, and small bowel doesn't require any process. Now you can see there, that is the middle colic which I've lifted up, and you can see the middle colic very clearly, and that is
Yes.
going all the way down to the SMA SMB axis. And here, if you can you see my arrow, or
No, sir.
no? Okay,
Yeah, yeah, we can see, we can see.
you can see the arrow, no? Okay.
Yeah.
So now I'm putting in the one extra port on the right side. So sometimes colectomies I do only with 3 ports, but in malignancy sometimes, and especially in fatty mesenteries, you need one extra port to lift up the colon and give you the traction. And you can see here I put one port on the right side, and usually that can be used later if one wants to drain the abdomen at the end of the surgery. So that is the middle colic. Again, this is the middle colic, if you can see. You can see my arrow?
Yes, sir.
Yeah. So this is the middle colic. This will be the SMA SMB axis, and lifting the middle colic tells you where the SMA SMB will be, and you can extrapolate that to where the ileocolic will be. So the ileocolic will be somewhere here, and this is the duodenum. If you can see here, this
Yes.
is the duodenum. So even in fatty people, a little bit of the duodenum will be visualized here. This will be the curvature between the D2 and the D3 of the duodenum. And this is classically where we would do a duodenojejunal anastomosis in D3 obstruction. So this is where it is visualized very clearly. You can see the ileocolic vessel, the right colic vessel, and this is the SMA-SMB axis. So now again, I'm moving the small bowel down. The small bowel does tend to get in the way, and especially you said if it's obstructed, it can be more difficult. It can be managed, but it's not great for a demonstration in such cases. Now you can see this small bowel has gone off the way.
Yes.
So this is
Some surgeons would prefer to put some gauze piece and pack that little longer gauze piece to retract the small bowel.
So I am not in favor of putting gauze pieces. People have lost gauze pieces inside the abdomen, especially if it's a fatty abdomen. So, and during the end of the surgery, one tends to forget, and towards the end of the surgery, one loses a lot of time looking for the gauze piece. Of course, you can attach a string to it and bring it out, but I don't like putting gauze pieces into the abdomen at all. The only surgery I probably use it for is a Heller's myotomy. Now you can see here, this is the ileocolic. You can
Yes.
see the pulsations of the ileocolic. Okay, and this is the middle colic. So this is somewhere where the origin of the ileocolic will be. and that is where we start our dissection. So this is the SMA-SMB axis. This will be the origin of the ileocolic. This is the origin of the middle colic. And our dissection will be centered on this area. We'll be pushing all the lymph nodes and the fibrofatty tissue towards the middle colic and towards the ileocolic and the right colic, and bearing the origin before clipping the vessels. Now, like I said, you can use monopolar also for this, but it's generally much cleaner with a ultracision or a harmonic scalpel if one has. This has made a huge difference to surgery, especially allowing relatively bloodless surgery. We hardly lose 100 ml of blood in a colectomy, and also keeps the fields clean. Now you can see the ileocolic completely stretched out.
Yes.
When you hold the axis up, the vessel gets stretched out, and this is the plane you have to go in below the vessel. Now you can see below the vessel the duodenum coming into view as we lift up the vessel. This is the duodenum. And here we go back to the origin.
Yeah. But while putting a harmonic onto that meso colon, how do
Yeah.
you know that the vessel does not lie below it, because the sharp or the vibrating
So you can see my hot
blade?
blade is on the other side, and the other blade is towards the vessel, as you can see. That is a little deliberate, though it doesn't really matter, because there is, especially this was not a very thin person, so there is a reasonable amount of fat on these vessels and fibrofatty tissue and lymph nodes, which you are expected to take. So now you can see I'm lifting up the vessel, and this is the duodenum. I'm lifting up the axis. Now you can see I'm tunneling under the vessel and exposing the duodenum. So if you go in the plane above the duodenum, and that is the correct plane to be in, and just below the vessels, that is where you will get all the tissue, and it is a plane of complete mesocolic excision. Now see, entire mesocolon has been lifted. What is left behind is the bare duodenum. So this whole thing comes out as one envelope. Now this is the blood vessel which I have lifted up. We need to bear it, push all the fibrofatty tissue up, and tackle it once all the fibrofatty tissue is gone and the vessel is bared. So obviously I think it's a little lower down. So I'm starting from even lower down than what we had previously. Now you can see the vessel coming into view here. I don't know whether you can appreciate where my arrow is. A little bit of bluish tinge, which tells you the vessel is coming. Then you have to be careful. A little bit of teasing helps. It opens up the planes and the strands for you, and then you can cut it. Very much
Sir,
like what you would do in a cholecystectomy.
Yeah, how are you sure that you are dissecting onto the right of your SMV, or so that you have taken the branch at the...
Now you can see this is here, this is the vessel, and this is the vessel where it's broadening. You can see it broadening here. It's getting a little broad here. So this is where the SMV will be. So here this vessel is looking broad comparatively. Can you see that?
Yeah.
So this is where it is the origin. So nowadays I also go to the left of the SMV and actually bear the whole SMV also, which I have not done in this particular case. That is a D3 dissection. It's not absolutely essential, not completely proven to literature. There are some studies very typical to the D3, what the Japanese used to do for stomach malignancies earlier, and now the same argument has come with colorectal malignancies, whether you bear the SMA axis or not, and we do that in few cases as well. But you can see now here where the vessel is getting broad. This is where the SMV will be starting.
Yes.
Now you can see this is the fibrofatty tissue and the lymph nodes, which we have lifted up and we have pushed upwards. Now you can see the nodes here. These are all the nodes. Now you can see the vessel from behind. This is the vein from behind.
Mm.
So there are some lymphatics and strands which are holding the lymph nodes together. These are nodes which have been picked up and pushed up. Now I'm pushing them up completely so I can bear the vessel. Now you can see the artery coming into view. Can you see that? And we are
Yes.
right at the duodenal junction. So we are at the absolute origin.
I will be actually afraid to directly go on with a harmonic active blade very near the vessel. I don't know. I'm just afraid because of maybe the blade becomes little hot when we try and use for a longer time.
Yeah, it does become hot. And sorry, did it close my presentation?
Sir, yes, sir, you can
Yeah.
just share the screen, sir.
We have Dr. Kanagwal with us and Dr. Tushar. So, Dr. Kanagwal, sir, I think you can take over the discussion further.
Thank you for Dr. Samir and apologies for joining a bit late. Uh, I've been very
Did you get my
carefully
screen?
watching it.
Have you got my screen?
No, sir.
It's right now, no.
No, Prabhu.
Sir, yes, sir, you can just
Pashupati?
share the screen. Yes, sir, not it cut, sir.
Allow to
Just
share
again,
window.
sir, again, sir, not it cut, sir.
Now you got it. Now
Now
you got
it's
it.
cut. Yes,
Yeah,
sir, yes.
Yeah.
it has
I
started
did.
from beginning.
I did put my phone off so that doesn't receive any calls. Sorry. So is this where I was? Yeah.
Prashant, do you by any way keep switching the table position to head up or head low at this point of time, or at what time you
Not
would
at
like to
this
prefer?
point. So this point, the patient is in a head low, so
Correct,
that the colon goes up towards the head end,
correct.
and the small bowel moves to the left. The patient is in a right up. So this is the position I'll maintain till I have to dissect the upper part of the transverse colon away from the duodenum.
Okay,
Then I give a head high.
okay, okay.
But the right
And
up is maintained throughout the surgery.
does location of the tumor, like ascending colon or a hepatic flexure, would like you to change your start of dissection point, or you follow
No,
your
the
same?
dissection point is always a CVL, a central vascular ligation. So the
Okay,
dissection is always going to start at the SMA SMV axis at the
perfect,
origin of the vessels. So
perfect,
either
perfect.
if it's a transverse colon growth, it will be at the middle colic vessels. If it's the
Yep,
right-sided growth, it will be at the ileocolic vessels. But the
correct,
dissection will always be centered around this point. So you have to make
perfect,
sure
perfect,
that your ergonomically your optics and your instruments are centered to reach this point, and then
okay.
everything else falls into place. And this is the point you take the maximum time over. And
Sure, sure, sure.
once this is done, most of the surgeries, rest of the surgery is just dissection of
Embryological plane
fatty
dissection,
plates. Yeah.
correct.
So the main thing in malignancy is taking the central vessels
Okay,
and pushing all the lymphatics. Now you can see here, these are all the lymphatic tissue which I pushed away. I bared the vessels here. Can you see that?
yep, yep,
Yes.
very nicely made.
Yeah. So now this is
And,
the bare vessel. All the fibrofatty tissue has been taken up with the lymph nodes. And
and the
with
way
even
you take the opening up of the Maryland also should run along the vessels. That's a very important
yes.
thing you are
So you
demonstrating
should,
so
yeah,
elegantly.
yeah. So you are tangential to the vessels when you put your instrument, and you are parallel to the vessels when you open your instrument. That
Perfect,
is very
perfect,
important.
perfect.
Yeah.
Mm,
So you can see the instrument is at right angle to the vessels, and then we
correct.
are opening it along the vessels, and that
And
is
how
very important.
often you get to see branching at an early origin level, or origin is
So in
always
this So in this case, you will come when we come to the middle colic, you will see it is splitting almost immediately, and
correct,
I got 2, 3, the right and left middle colic just at the origin. So I had to take them as
correct,
separate vessels, but it doesn't matter. Whatever it is, you are bearing the origin of the vessels. You take all the
correct.
fibrofatty tissue, and then you take the vessels when they are bare. So once you have done that, you are oncologically sound.
And your camera person is retracting the hepatic flexure. You are alone holding, sir.
No, I have put one extra port in this for retraction of the hepatic of the
Correct.
colon, transverse colon. So
Okay.
the staff nurse or the second assistant is
Yep.
pushing the transverse colon towards the stomach.
So it gives
So
a
that is
bone
the,
arrow effect
yeah.
then.
So now
Correct.
now you can see here that is a vein and artery, both separate. And I always prefer to use these clips. These are the ratcheted clips, the wet piling or the Hemlock clips, and
This is
these
a
I
5
feel
mm
are.
device or a 10 mm device,
This
Prashant?
is a 5 mm design. Currently, I have only 5 mm instruments.
Okay. Okay.
I have one 10 mm for the scope, but the other two are
Correct.
5 millimeter.
Perfect. Perfect.
And only at the time of stapling, I change the 5 millimeter to 12 mm.
Perfect.
So that is because, honestly speaking, if you put a 10 mm, then you have to use a reducer, and you ideally require a 12 mm. And
Um,
if you use a 12 mm, then sometimes, when you're putting 5 mm instruments, there can be some leakage and all. So that is why I
Perfect. Perfect.
replace it only at the time of stapling.
The concern was to ask you, when you
Uh,
use Liga clip, do you have length limitation when you're using a 5 mm? That's where we end up using a bigger one, using the 10 mm Liga clips.
So if you have
So
a very large vessel, but honestly speaking, most
5
of
is
these vessels,
sufficient.
if you bare them completely of the fibrofatty tissue, they are never
Perfect.
large. They are never large enough to require a 10 mm clip.
Got it.
So
Got it.
the reason why you need a 10 mm clip is if you are not bared the vessel completely, and there's a lot of fibrofatty tissue on it, then you feel that it's very thick. But the bare vessel itself is never so thick. Sorry, to require a 10 mm clip.
And how often you can do this with the ligature?
With ligashure,
Yep.
I have done entire hemicolectomies, not only with the ligashure,
No, for the
but
vessel, I'm asking.
even for the vessel, I'm saying.
Okay, great.
Entire hemicolectomies with a ligashure, and not only with a ligashure, I've also done it with a harmonic scalpel without using
Yep.
any
Yep.
clips at all.
Perfect.
So when the ACE came, the
Hmm.
harmonic ACE, I felt it was good enough to take all the vessels, and
Super.
it would. But honestly, this makes me sleep better at night.
No, no,
So
I'm fine with the way and safety measures. You're taking doubly clipping proximally,
yeah,
and your left hand is rock hard and steady, and no excess traction all through, and there is no
yeah.
jerks whenever you are taking
So
it in. These are all
that should
lessons
be in
for the
the
youngsters.
that should be in the surgeon's hand, the
Correct.
left traction. That should be in the surgeon's hand.
Yep.
And now this is the vein, the artery I have taken. You can see the pulsations, and this is at the origin. And now I'm taking the vein. Again, as you said, one proximal clip would be sufficient because I'm also using harmonic, but
Perfect.
just to be safe.
Yeah, Prashant, I have a question.
Yes, sir.
Yeah, so how frequently would you encounter the Henle's trunk here, and how do you manage that?
So, like I said, all the fibrofatty tissue should be bared and the vessel should be bared. So then it doesn't matter what trunk you're dealing with. As long as you take all the vessels going to the colon and spare those going to the pancreas, you are fine with that. And occasionally at this, even if you take the pancreatic or duodenal-pancreatic vessels, it really doesn't matter.
So normally, how many nodes you get in your conventional radical hemicolectomy, Prashant?
So we always get more than 20 nodes.
20.
And yeah, and they say in literature that more than 12 is sufficient,
Yes,
but
yes.
12 to 15, but we always get more than 20 nodes. It's
Fantastic.
very common to get more than 20 nodes. In fact, I've even got once 50 nodes, but
Amazing. No,
that depends patient to patient. So
correct. And then, do you have any maneuvers for super obese or very fatty mesocolon?
sometimes for the super obese, you require more ports. You should not hesitate to
Correct.
put extra 10 mm, 5 mm ports to
Okay.
retract. Now I'm going to the middle colic axis. You
Yes.
can see here. Yeah. So whenever you have a problem with the retraction or visualization, then it's time to put extra ports, and you should not shy away from that because a
Yep.
5 millimeter extra port doesn't add any much morbidity, but it can make your life much simpler. Like I said, most hemicolectomies I do with just three 3 ports, 1 optic and 2 operating ports. But for the radical ones and the fatty ones, sometimes, like in this case, I put 1 extra port. Sometimes even 1 more extra port is required. Now you can see the middle colic here. If you can see my arrow, this
Yep.
is the middle colic, and this is the fibrofatty tissue. I'm bearing it. This is the origin of the vessels.
But sort of you do the dissection also with harmonic. Somehow I'm fine with Maryland, little to open, and then you seem to be very flamboyant in using harmonic for dissection as well.
Because it takes care of all the small little blood vessels and gives you a
Correct.
bloodless field, I feel.
That AS is very comfortable, right? So
Yeah, yeah.
that is little more
Now you
towards like a
can see
Marylandish type.
this
Mhm.
is the duodenum and pancreas, and this
Great.
is the complete mesocolic excision, and this is all the fibrofatty tissue and the lymph nodes that we have taken with this. So here one has to be a little careful. There is a danger. If you don't find your plane properly, you can dig into the pancreas. So one should be a little careful here. And you can see when you get a bloodless plane like this, you know that you are in the correct plane of complete mesocolic excision.
Prashant, you doing just a radical right hemicolectomy, or are you going for extended?
Extended in the sense I'm taking the middle colic vessels because
Okay,
it's
so how
hepatic
far into
friction.
the transverse colon you'll be going as far as the staple is concerned?
So as far as the stapling is concerned, after taking the middle colic, I go to the left of the middle colic and more than 10 centimeters from the growth. And usually that is sufficient.
Okay, so basically you're doing a hemicolectomy along with taking the middle colic, right at the
Middle
root.
colic, yeah. So if you're doing a classical right hemicolectomy, you take only the right branch of the middle colic or completely leave the middle colic alone. When you take the entire middle colic, it becomes a little extended because you're going to the left of the middle colic.
And how would you ensure the vascularity of the
So now
distal
you
part?
can see here the middle colic is a very early division into the right and left branches. And again, I have bared these vessels. So I've taken all the fibrofatty tissue and the lymph nodes up, and the vessels are completely bared. My cameraman has turned a bit, but otherwise they should be straight up towards the sky.
And in cases where you have a lot of lymph node load, the load of lymph nodes are huge and presence. How do you handle? You roll everything out, and if there are
Yeah,
presence
so
of
the same way you can see this, all this is the lymph node mass, which has
yep,
been lifted off like a blanket from the
correct.
vessels. And you lift it off from the vessels and you expose the vessels, you will get the bare vessels, which you will see. And you see it in this manner.
Yep, yep. And
And then you
what
will
is
clip when the bare vessels have come. And then you can go, once you have bared the vessels and you're going all the way up. So that is oncologically enough.
and how often you use neoadjuvant therapies in right colon
Colon,
malignancy?
colons almost never. So rectums always yes for mid and lower rectums.
Hmm,
But colons is very rare unless I find it looks a little inoperable to begin with, and it is very adherent, maybe say ureter involved or some contiguous organ involved.
correct.
Then we might use neoadjuvant therapy and try to shrink it. But experience with neoadjuvant in colon per se has not been great, at least for me. But for rectum, yes.
The world seems to be migrating to neoadjuvant for the entire colorectal malignancies as well.
Even for
Because
colon.
yes, yes, yes. And the next thing which is very hotly coming up, especially for the high volume centers, are the one with the HIPEC, etoposide or single agent HIPEC for all colonic
But
resection. Not
but
as a approved protocol, but most of the
uh,
centers will
because
do.
HIPAC is not proven to improve survival in
Correct,
colorectal
correct,
malignancy.
correct.
In
In
fact,
Chennai, the
when
cancer.
HIPAC came, they were very aggressive about it. for colorectal malignancies, but it has not shown to be of proven benefit, at least as of now.
Here in Chennai, 3-4 centers have joined together for a trial, Cancer Institute and other private
Yeah,
hospitals.
so as a trial, yes, I agree with you.
So
We are still
right
we are
now,
still we are still
right now,
trying a
yep,
lot of things in malignancy, but on a trial basis. It's
yep.
not proven and it's not standard of care as of now. Now this is the right colic. You can see here, this is the whole envelope of the fibrofatty lymph nodes. So you can see you should keep your one eye on the duodenum and the pancreas below so that you don't dig into that. And that is very important at this particular stage as you go up towards the uh, hepatic flexion of the colon. And now once all the vessels have been taken, you're less worried about, prodding the tumor, but we still try to avoid any prodding of the tumor uh, throughout the surgery to prevent any spread. So now you can see here, this is the duodenum.
Yep.
This is the plane. Little bit of bleeding there. So sometimes bipolar works better if you get a bleeding point.
Sure.
This is the second part of the duodenum. Sometimes it has been, if the malignancy is very close, there have been occasions where I had to pinch off a wall of the duodenum and suture it. And sometimes you need to do that if it's necessary. Now this is where we identify the ureter. We are going, now you can see this is the proper plane or the line of Tolt. And if you go into the correct plane, it's usually avascular like this, and the ureter remains behind. And there is a facial plane. You can see this line here, and this is the line of Tolt, and which would be from the other side. You can see here, and this is the fascia, where it's very clearly where we are coming to the lateral wall. And the ureter remains behind this facial plane. So you have to preserve two structures when you're especially doing the right colon. One is the ureter and one is the duodenum. You have to keep them and at arm's length. And if you go in this correct plane, it's a bloodless plane, and it will usually open up for you very well. Now you can see here. And as you go higher up, you will get the Gerota's fascia, which you need to keep away. And it's very easy to enter the Gerotas if you're not in the correct plane and bare the kidney, which is again unnecessary, not very harmful, but still unnecessary. And it just skews up the planes for you.
So, Dr. Prashant, if I am supposed to summarize it, if you're sticking to the Tolt fascia and putting it behind, then the ureter, the gonadal vessels, as well as the duodenum stay behind and we go in the right plane. Am I correct?
Correct. Absolutely.
Yeah. So that's a very nice thing Dr. Prashant has demonstrated. So we always have to endeavor to stay behind this, just stay just under the plane so that we are safe, bloodless, and we are going fast.
So now we are going to the upper part of the transverse colon to take the greater momentum and the gastrocolic omentum. And here you have to preserve the gastroepiploic vessel, the gastroepiploic vessel, the right one, and leave that on the stomach, and the rest of the omentum comes with the colon. Now you can see that is the greater curvature of the stomach, and here is the gastroepiploic vessel. You can see this is the gastroepiploic vessel. So I am sticking below the gastroepiploic vessel, and this is all part of the omentum that will come with the colon. Now, Dr. Kanagal was asking, in this particular position, you can put
Yep.
the patient in a head-eye position
Correct.
and
Correct.
let the colon come down. Now you can see here, this is the stomach, and this is the
Yes.
greater curvature of the stomach.
You just leave the
And you
epiploic
just,
alone.
yeah, just leave the epiploic on the stomach, and the rest of the things come out of the colon. And that gives you a good plane actually. Here is a little bit where it was stuck to the gallbladder.
Yep.
Again, the omentum was stuck to the gallbladder, not the tumor. The tumor was not very infiltrated like that, but maybe some cholecystitis or some infection in the past year. Now you can see here again, you will get a bloodless plane if you go
Yep.
in a
Yep.
proper plane.
And, thanks for showing a video which shows here and there bleeding, unlike people who end up showing a very nice RBC free videos. So this makes people to try, because people who do colons will definitely appreciate this, because
So thanks for telling me I'm a bloody surgeon. So now you can see from below we have got a window to the other side. You can see this window. Yeah.
yep, yep.
So that is in the mesocolon. That is above the vessels. Now you can take the mesocolon along this level. Now again, this is the duodenum.
And audience should be aware, then we should have be looking forward for more than 1 or 2 layers of dissection here you need to do, depending on the obesity index of these mesocolons.
Yes.
So it's very elegantly shown that either side he is having control,
So
and then he's
you can see
progressing.
here.
Yeah.
Yeah. This is the gerotas which will be coming here.
Yep.
And this is the hepatocolic ligament, which I'll be taking.
Yep.
Now again, like I said, here this fat is gerotas. This fat is hepatocolic ligament. You have to find a plane in between the two. And you can see this is again the plane of Tolt. You can see this here.
Yeah.
This is the
Yeah.
plane.
Yeah.
This is the bloodless plane. You can see that.
Yes, correct. The
That
embryological
is the
plane opens
bloodless
up
plane. Yeah.
nicely.
So this is the gerotas, and it's very easy here to make a difference and go into the gerotas.
It
But you
gives
don't want to
way,
do
right?
that.
It gives way,
Yeah.
exactly.
Yeah. Yeah. So if you correct in the line of Tolt, it will give way properly.
Mm.
Yeah.
And this is all flimsy tissue. You can take. The gerotas has gone down.
Yeah, very nice, excellent.
So now once we come here to the hepatocolic ligament and you're taken it, you go along the lateral wall. This is the what you would have done initially if you're doing a lateral to medial mobilization. But since you've gone medial to lateral, this is the last thing you do.
Correct.
And finally you take this is the appendix. You can see you come down there from high up, because your entire thing is separated. So what remains is only a transplant layer now to take.
This is a male patient, Dr. Shan.
Yeah, this is a male patient.
Okay.
Male, no? Yeah, when we look down towards the bladder, you could see there were no ovaries or. So now this is the mesentery of the small bowel. Now the entire colon is free. Only the small bowel remains attached with this mesentery. And you cut the small bowel with the harmonic. You can cut right up to the skeletonizing the small bowel.
Yes. And are you
So you
planning it
have to go.
intracorporeal?
I'll show both.
Okay.
This particular patient, I think, was done extracorporeal, but I'll show
Okay.
you
Okay.
intracorporeal and extracorporeal. So that
No, but
I prefer intracorporeal, and the only reason to do extracorporeal is the patient is not affording staplers.
Correct.
Otherwise, I always do intracorporeal anastomosis. Now you can see
And
this
does
is
your
the
dissection vary between intra and extracorporeal at this level, at this point of dissection, or
no,
you
because
also?
the entire colon is anyway free. So if you want to bring
Okay.
it out for extracorporeal, it comes out. Now you can see here, this is the small bowel wall. We have come almost up to the wall, and here a little bit of colon is stuck. You can see that. So now this is the colon entirely free. And similarly, as you skeletonize the small bowel, you also have to skeletonize the transverse colon where you're going to divide it. So clean it of all the fibrofatty tissue and the mesentery and the omentum.
Dr. Prashant, in the entire surgery, we can appreciate that the small bowel is completely out of the field. So can you
Yeah,
just
so
give
we
me
are given a head low position and right up position. So that
and
pushes the small
how much
bowel.
up by 45 degree or how much less?
So it's about 30 degrees, I would say, head low and right up. So basically, I give it till the anesthetist starts screaming.
That's a very nice tip you've given.
At one point, they start shouting at you. So
Yeah. So
you
basically, the
stop.
surgeon should be happy and the anesthetist should be happy.
Yeah.
And I think you guys use medical air rather than nitrous, right, Dr. Chan?
So yeah. So now this is the mobilization complete. After that, there are two ways of removing the specimen. One is you can put it into a bag completely, or you can remove it through a fan and steel or the umbilicus only if you're doing a extracorporeal anastomosis. If you're doing a intracorporeal anastomosis, then I prefer to remove it through a fan and steel because then the scar is less seen. Otherwise, you require a slightly bigger scar at the umbilicus. So either way, if you're going to take it out, the specimen should not touch the wound when it's coming out. So it's very important that it goes into a bag. And if it's not going into a bag, the other thing you can do is use a wound protector for the fan steel or the umbilicus and to get it out. Now you can see the specimen has gone into a bag. You require a fairly big bag because a large amount of momentum also. And you can put a clip to hold the bag closed. So now doing an intracorporeal anastomosis for the small bowel, I always prefer to use a blue cartridge. I've seen Palani and a lot of people using white cartridges. So I've always been using the blue cartridge for a very long time, and I'm comfortable with that. So again, you make sure you're going perpendicular to bowel, and you can see that line. Usually these staples have a safety feature where the stapling falls short of the knife. And sorry, stapling goes beyond the knife, or the knife falls short of the staple line. So the last bit you have to cut, and it is always heartening to see bleeding at the cut end, and because it means it's not devascularized bowel. Similarly, for a colon, I use a green cartridge where the staple leg length is slightly more for thicker tissue. And this is again at the point where we have completely skeletonized the colon. You can see the green
You are
cartridge
coming
again.
from the
Try.
umbilical port, Dr. Prashant, the
No,
stapler.
no, it's a left hypochondriac port. My
Okay.
main operating port has become a stapling port.
Okay.
Dr. Prashant, you take on ICG at this step?
I don't feel it's necessary. I've never used it for colon. And honestly, wherever I have seen ICG being used, even before the use of ICG, I could tell whether it was viable or not. So I don't think it's really changing it that much. Maybe to a less experienced surgeon, it's helpful, or maybe in the future for documentation for medical legal purpose. So now we make enterotomy between the small bowel and large bowel and the transverse colon. And again, a blue cartridge for the anastomosis. You have to pull both the bowel ends so that the entire 6 centimeters of stapler is used for the anastomosis.
Do you have any tips for handling this when there is an acute obstruction?
Well, in obstruction, you have to have a good suction ready, because when you open the bowel, usually there's a gush of contents out. So now you can see this is not very
Well prepared, maybe.
this is reasonably well prepared, and but like I said, I don't use any bowel preparation for right. So unless patient is obstructed, you don't see too many contents in the. So now this is a 3,0 polypropylene, which I use for almost all anastomosis of the human body, and unless one needs a absorbable one in bladder or bile duct. So this is and we always start at this corner, which is the posterior corner, because my fear is if you start anteriorly, then sometimes you can lose this corner when you come to the end. And we start from inside. The knot is from inside, and at some point at the corner where we turn
Anterior.
around to anterior, we will get the needle out and go over and over.
Okay. I
So at the
usually take a tag to retract, so take a stitch to retract. That helps me easier. But this also looks very comfortable to you. At
you
one
don't
edge, I
need
usually.
you don't need anything to retract the thread. Your hand holds it and pulls it. See, like your left hand holds it up and gives you the traction required.
Dr. Prashant, any specific reasons why you would use a proline over a, say, a PDS?
PDS.
No, like you said you're using proline.
I've been using proline before PDS came into the market.
Okay.
So I continued the same. I've been using proline since residency, 1995.
Okay.
So I don't think PDS was even available in those days.
No, I do agree. It is not available. It's a new kid on the block. But
Yeah.
I thought it would give the same
So
advantages of a proline.
I haven't had problems with proline. So I see no reason to change. I agree. Nowadays, people use a lot of PDS, etc.
To add up to Tushar's viewpoint, proline are sort of a little firmer than PDS. PDS is more
Yeah,
dexterous, a little more dexterous to handle and not.
I like this polypropylene material a lot.
Mhm.
I think even though people say it has memory, etc., it's a very fine thread. It's monofilament. I feel much better than polygalactine 910, which is, as you know, Vicryl. So I think this is far better. Like I said, PDS came much later into the market, and before that we were using this, so we got comfortable with this thread, and reasonably low complication rate. So see no reason to change.
Any take on Bab suture?
For bowel, I have never used. A little concerned. I use it for closing my hernial defects, but a little concerned about using it for bowel because of the barbs. The reason why I use polypropylene over Vicryl is that it is monofilament. So using a barb which is more, abrasive to bowel than a smooth monofilament has always worried me. The second thing is the biggest advantage of the barb is they say that you don't have to knot it. Now, not knotting it in a bowel anastomosis would also concern me. So, there's enough now literature out that people are using it. And I also spoken to people who are using it and are very comfortable with it. I'm just worried about my bowel anastomosis. So one thing you will notice, this is a isoperistaltic anastomosis, but it doesn't matter even if you want to make an antiperistaltic anastomosis. These always become a side-to-side anastomosis, and sometimes the lie of the bowel may make you make an antiperistaltic one. I don't think it really matters, especially if I was taking the bowel out and doing an extracorporeal anastomosis, and you're finding end-to-end stapler. Usually both the stapled ends comes out, in which case it becomes an antiperistaltic anastomosis. But here the lie of the bowel I have kept in such a way that it's isoperistaltic. So now we have come to the end, and I usually double back in a seromuscular. Again, that is not essential, and I have seen a lot of people not doing it nowadays, especially I think Palani does it in a single layer. And I've just been comfortable doing at least the colorectal anastomosis, not colorectal, the ileocolic anastomosis this way. If it was purely colonic anastomosis, sometimes I do single layer. And this is what is called as the three-leg tie, in which you got a ending off with a loop. Another word of caution is you can see in my left hand I am using a Maryland. So when you are using a Maryland, you have to be a little careful that you don't crush the thread, because the Maryland already, of course, is like an artery forceps. So if you crush the thread, it can crimp at that point and sometimes weaken at that point. So you should hold it very lightly, or use a non-traumatic grasper to hold it, or a needle holder. Some people use the needle holder in both hands. Now we are doubling back for the seromuscular layer. There's no danger of making the anastomosis narrow, because it's a wide 6 centimeters side to side, and this is just the enterotomy you are closing, which only adds a extra centimeter, a couple of centimeters to the anastomosis, because it's again a side to side enterotomy closure, small bowel to large bowel. So earlier, some people also use a staple to close this enterotomy. In such cases, you have to be a little careful of narrowing the anastomosis, because the stapler takes some space, and it might cut into your anastomosis itself. Are you there with me?
Yes, very much.
Yeah.
Yeah, we are
So
there
the
with you.
other way is, sometimes I have done this, is the so-called Barcelona technique, in which you do a side-to-side anastomosis first, and then you staple off the enterotomy along with the bowel.
That works well when you take it out for an extracorporeal.
Yes.
It gets
Yes.
over in few minutes, bang out.
Yeah. Yeah. Sometimes I have used it even for intracorporeal.
Yep.
But it doesn't always save the stapler, because sometimes even for the Barcelona closure, you end up using two staples. Now you
Yeah,
can see
200.
here, you have to go back to the where you had started off, to the posterior part. and lift the bowel and finish off the.
With the 8 centimeter staple line, it sometimes works. If you have a 80 millimeter one, it does work. The
Yeah,
muscle nut.
correct. So that is the intracorporeal part. Now, the other colectomy we do sometimes is a single port colectomy. And in this, you can see this is a single port, which we are using at the umbilicus. And this is how the ports are designed. So multiple valves they have. So you don't need any other port. And the optics we use is it's called the endo eye, which is a flexi tip telescope, so that it helps you to go over the colon. And you have a little less flexibility of the instruments because they are going. We have time now, Samir? Or we are done? Now you can see this was a
No, no
cecal
problem.
growth.
Continue.
Yeah. So this was a cecal growth. You can see here. Now
Oh,
again,
young
this
this
was the
chap. Oh,
very
young
young
this.
chap actually, very
26
young chap,
years.
26-year-old. Now you can see the SMV here.
Yep.
Now
Very nice.
26-year-old came from Singapore to get married and found out he was anemic and came to me. And during the course of investigations, we found a cecal growth. It's amazing. Now you can see here again the lymph nodes being pushed away from the SMV.
Correct.
SMV has been bared in this case. And here you can see the pancreas coming into view. Now this is again the lymph node and fibrofatty tissue. This is the SMV bare here, which you can see. And this is the ileocolic vessel coming off from the SMV. Now you can see the vessel has been bared. And the bare vessel has been clipped. All the lymph nodes and fibrofatty tissue are away. Again, it's the same vision you get. You can see the duodenum right below.
How constrained is your work with single port, Dr. Chand?
So now you can see the SMV has been completely bared here. Can you see that?
Yep.
Yeah. So, in thin patients and in suitable cases, I feel it's very good. Now you can see here, these are the continuation of the SMV, and all the vessel is completely being bared. And all the fibrofatty tissue is
Notes
being
are
removed.
taken off.
Yeah, nodes are taken off.
Dr. Prashant, I would understand the steps would be essentially the same if you're doing
Yes.
a single port or multi ports.
Yes.
But
So
I
you
would
can
be
see here.
interested to
See here.
if you can talk about the instrumentation what you're using and the
Yeah.
problems
So
what you
this is
face when
the
you're doing single port.
this is the ureter. Now you can there were three problems when we started doing single port surgery. One is that there was a chopsticks effect of the instruments, because you can see here they are like chopsticks, almost parallel to each other. You don't get the triangulation, and they clash with each other. So the movement has to be inside outside rather than side to side, as you would flail your arms in a regular laparoscopic surgery. And that is the main difference. And the other thing is that the light source, which is normally tangential and perpendicular to the telescope, was clashing with the instruments. And that is why this is the right colic vessels. You can see the lymph nodes being taken off. And because of that, we started using this endo eye, which is a coaxial light cable, which doesn't have a light cable which is perpendicular. So now you can see the pancreas, which is bared. This is the pancreas, this is duodenum, this is the SMV, this is the right colic, and this is the ileocolic. So here we didn't take the middle colic because of cecal growth, and we just took the right colic. The SMV is completely bare here. It's almost like a D3 dissection. So we surmounted this, and then we started using bent instruments to help us, and articulating instruments. We helped to develop also some companies developed articulating instruments so that we could use them. Cambridge Endo had them. Olympus used our help to develop some of these instruments. And you can see this is a complete mesocolic excision again. The pancreas here, we are going in this is a thin patient. So you can see when you go, you can go all the way to the hepatic flexure here. And you got the window. and the hepatic flexion. And this is finally the hepatic flexure being taken. So here you have some difficulty when you're doing single port because the instrument is coming from the umbilicus and not from the right side. So
Correct.
here if you have an articulating instrument or a bent instrument, it goes over and comes down and helps you. Now you can see the duodenum, gallbladder, and the gastrocolic and the hepatocolic momentum is being taken.
Retraction, you take a thread retraction, needle and thread retraction, or don't retract at all?
Don't retract at all. Now you can see the finally everything is done. We have gone to the growth, and it was a little stuck to the peritoneum here, so we are going wide and taking the peritoneum is also the parietes. It was not really invading the parietes, but just a little stuck to the peritoneum here. This patient did well with chemotherapy.
Excellent.
So now you can see going all the way to the hepatic flexion. Now you can see in that other case which I did, I came from up, but there my instrument was in the right hypochondrium or the left hypochondrium. So, and then this is the other anastomosis I was talking about. Now with the wound protector, the single port acts like a wound protector. You got the whole specimen out, and you do your anastomosis in an open way like you would do in open surgery. Again, this fellow had some constraints of cost. So, and now this is the finished anastomosis. We have a look inside again. This is the, you don't necessarily also have to use a drain in such cases because you don't have a port for a drain laterally. And this is what it looks like after you finish.
Excellent.
Very small incision.
Excellent. I think it's less than smaller than the specimen
and this is the
extraction
whole
size.
specimen which is removed. And this is the growth.
When you do an extraperitoneal,
yes, extracorporeal or extraperitoneal.
Yeah, when you do an extracorporeal anastomosis, how are you sure that you have taken care of the intermesenteric opening? Because usually it is brought out through a very small opening, and personally I feel it need a suboptimal closure.
No, we go back inside. I never close the mesentery.
In either or?
Either. I never close the mesentery. And there is no advantage of closing the mesentery in literature. You just make sure there is nothing herniating when you leave the patient. When you close
the
the
bigger problem what I face during my cases, like my worry in fact is not the herniation. Of course, I do usually close, but the bigger problem is you have to make sure that this is not to twist. You're likely to twist and anastomose, so that should not happen.
No, no. If you have got mesentery to mesentery, there is no question of twist. Mesentery to mesentery.
Yeah, but as you rightly said, I would always try to go in and scope it again.
Yeah, I have scoped in again. I showed you. So
yeah.
If you see, I went in again after this.
Yeah.
This is going in and having a look at the anastomosis, and I always make sure that nothing is herniating in the mesentery. See, this is the anastomosis. You can see here. Give a wash, see the anastomosis proper, nothing is herniating. That is essential. You have to go back and see to make sure that it's the lives proper. Because if you have pushed it in wrongly, or if there's a herniation when you leave the patient, it's a problem. But like I said, in literature, there is not much difference. But some people say that faster return to work, recovery of bowel function, and decreased morbidity with intracorporeal anastomosis. But you can find literature either way. But more or less, a lot of literature is skewed towards intracorporeal anastomosis. So like I said, my only reason for extracorporeal is if affordability is a problem. So all these myths about colorectal laparoscopy in colorectal malignancy have been busted. We know that. And now even some reports of maybe improved survival are also coming. Of course, the Lacey trial initially had showed increased survival in 2002, but nobody has been able to replicate that. But now there are a lot of other studies also coming. When I started doing these in 1997, I faced a lot of backlash from oncosurgeons. And, if even a stage 3 malignancy I operated and patient was unfortunate enough to get liver mets somewhere down the line, he would go to an oncosurgeon and he would say that because this fellow has done it laparoscopically, it's come back. So, and now oncosurgeons are trying to learn laparoscopic colorectal surgery. So we have faced these problems when we started this, but now Like I said, my first colectomy was done in 1997. So it's been almost 27 years. And it has stood the test of time. And I've done hundreds of these procedures now. We are very comfortable. And I think it's an excellent procedure. Uh, and you can give a lot of, there's a lot of literature also now, which gives a lot of benefit. And there are literature about single port surgery also. And I think for colorectal malignancy, according to me, it has become the gold standard as far as I'm concerned. But and I think literature also bears out that it's much better for than open surgery.
Uh,
And
I do agree with you, sir. I would
Yes,
talk about both the laparoscopy as well as ERAS. Both the things have, in combination, come a big way in colorectal surgeries, and I think that is the new way in and the new way forward. And as far as the single port
correct.
surgery is concerned, am I audible?
yeah.
yeah, you're very much audible.
Yes,
So as far as single port surgery is concerned, I remember you had once. No, that's there. I had seen you in somewhere near one place near Ahmedabad, where you had demonstrated a single port cholecystectomy way back in, I think it is in
yes,
2007 or something like that. And
yes.
today
In
I see
Nadia,
you doing
that's
a
it.
single. Yeah. So today I see you
In
single port
Nadia,
doing
it was
correctly, really nice.
acute gallbladder demonstrated in Nadia. It was a difficult case, I remember. And they had also given me something what is called as a Eunice syndrome or Yusuf syndrome, which is a, fistula between the uterus and the bladder, I think, to operate for a single port. It was a very unusual case, but yeah, but all it needed was a hysterectomy and closure of the fistula. So I think single port, yes, in selected cases, but off late, I'm also getting lazy. I don't push it. And when patients ask for it, some people come to me specifically asking for it, and then I give it to them. Otherwise, it's much faster for me also to do it standard laparoscopy than single port surgery. So as you get older, you want to take the faster way out.
The ergonomics play a different role itself in single port, and it is not
Yeah.
everybody's cup of the tea that he can
Okay.
do it. Rather, safety
Yes,
profile,
absolutely.
at least a gallbladder, that you cannot see ahead of what you're clipping, and that is usually preventing many people in venturing into single port, because in
Correct.
multi-port at least you can
No, but in
go ahead.
single port also, I can show you a very good critical view even in cholecystectomy. So I think again that is depend or very operator dependent. You can see you don't necessarily have to compromise on the critical view. And if you feel you're compromising, always add an extra port. We call them rescue ports. So you add one extra port, it doesn't matter, no? So you can have one extra port. So especially in difficult gallbladders, empymas and all, sometimes you have to leave a drain. So you add an extra port in the midclavicular, which helps you for the dissection, and that is all that it requires. So I don't think it's that bad a thing, but people should be sensible. You should not be overtly aggressive about it. At the same time, common sense should rule. If safety is of paramount importance more than cosmesis, always. We also say that in laparoscopy versus open surgery. If you are in trouble, we always convert. I mean, nowadays we hardly have to convert, but still, it is the dictum that if you are in trouble and if the patient is at risk, you should always resort to open surgery. Open surgery is, of course, what we all learned on. So I don't think it's a bad thing. You know, ultimately the patient should be safe.
Perfect.
Yeah.
Any more, sir? Dr.
Maybe
Kanagwal?
I can ask a little more challenging thing. How often you get to handle leaks and stenosis done by someone else, and you still prefer laparoscopic one or open one? What is your experience of
So,
that?
leaks. I rarely encounter nowadays in my practice, but occasionally when you get them, the best thing to go in and bring all the bowel out and let the patient settle down, and then as a cold case, manage to close it rather than
Well
try
said.
anything when the bowel is inflamed. Yeah, and for me, it's always to put a scope in and then convert. Conversion is always there, so it's not hard and fast unless the patient has been operated multiple times, has got multiple scars in the abdomen. Then common sense dictates that you don't waste your time, put in a scope, and then making things even riskier. You just open up and do it. So, but other than that, always it's preferable to have a look with Scopy first and then see what is there.
I think Dr.
In
Tushar.
colorectal, especially if you are doing, if you are dealing with colon and if it's a leaked colon, please don't try taking stitches and all. They're not going to work. Bring out both the ends. Let the
Well said,
patient
well said,
improve.
well said. Mm.
Yeah, let the patient improve nutritionally. Get the patient well built up,
Safety
and
of the
then
patient.
you can close it. There is never any hurry in that. And recently, I had even occasion to operate on a patient who had come, who was operated somewhere for a ETEP and had come with a bowel leak. And
Oh, oh, oh.
again, yeah,
How
again,
sad.
I just brought out the bowel, and I remembered because he had come now for closure. So, but the best thing is to in contaminated abdomen is just to bring out the bowel,
Bailout.
let the patient settle down, and then to close it. So.
So I think I, I should thank Dr. Prashant Rao for
Thank you.
helping me out at the last moment when suddenly we had some issues and showed a phenomenal demonstration of right extended hemicolectomy. Dr. Palaniveru sir had shown a similar kind of extended hemicolectomy, but he had taken a tunneling technique which went below the level of small bowel mesentery onto the right side, and he went over above the plane of tolls, and this was another experience, so another way of doing the same procedure in a refiner way as what Palanivilo sir did it. uh, I will thank Dr. Kanagvel, Dr. Tushar, and Dr. Kunal also for giving their valuable time. One call, and I think both had agreed immediately. Before we end, I'll just put up some few. I think next month we'll have a similar program. I think on 16th of January it would be mostly endoscopic thyroidectomy. It would be done by Dr. Gyan Prakash from SGPG at Chandigarh. Uh, our forthcoming events would be we are having MMAS course in hernia, which will be at Jaipur, and the mega event from 20th of August to 31st, Amasi Con. So my sincere request to everyone to please register. Uh, we'll have Amasi online CME series will be done, which is the 25th in line on 2nd of Jan by none other than Velu sir, which will be on 2nd of Jan at 8 p.m. Uh, and uh, 109th Amasi skill course coming up in Bangalore on from 10th of January to 12th of January 2025. Uh, MMAS
Thank,
course, which is a specialized course in hernia, where their online lectures would be from 27 to 29th of Jan. Then the live surgeries along with the physical lectures and demonstrations in Jaipur, which will be at Rajasthan International Center. The physical meet will be from 31st Jan to 2nd of February. This is the first MS hernia course, so please, interested people, please register for it. It would be something new and something exciting for all herniologists to attend and get prepared for newer ventures in hernia.
thank you, Samir, for the invitation, and thank you for Amasi.
Yeah.
Always a pleasure to be with Amasi. Thank you so
Thank you.
much.
Thank you. I'll
Thank
thank
you, Samir.
everyone.
Bye.
Thank you.
Bye, Tushar, and thank you, Prashant, for
Bye. Thank
wonderful
you. Thank you
demonstration.
all of you.
Look
Bye bye.
forward for
Thank you
more
to all the
deliberation.
chairpersons.
Thank you,
Thank you.
Amasi.
Yeah.
Thank you, Dr.
Thank you.
Samir. Thank you, Ramasi.
Yeah.
Thank you, Prabhu.
Welcome to Merrill, where innovation meets precision in every suture we produce. Discover the meticulous manufacturing process behind our endosurgery sutures. It all begins with the finest raw materials, rigorously selected and tested to meet Merrill's exacting standards for strength and biocompatibility. Our advanced extrusion and braiding processes create sutures with uniform diameter, smooth surfaces, and optimal handling characteristics, ensuring consistent performance in every strand. A precision coating application further enhances the suture's performance, providing smooth passage through tissue. Every batch of Merrill endosurgery sutures is subjected to stringent quality control tests, including tensile strength, elongation, and biocompatibility assessments, ensuring reliability and consistency. Our automated packaging lines ensure that every suture is packed with precision, maintaining sterility and integrity, ready for use in operating rooms worldwide. Each suture undergoes rigorous sterilization processes, adhering to the highest safety standards to ensure sterility and patient safety. Before our facility, each suture undergoes a final inspection, ensuring it meets our quality benchmarks. Only then is it dispatched, ready to support surgeons in delivering the best patient outcomes.